What I want to give a talk, base my conversation today is two aspects. One is to update on radiation safety and then spend some time on the dose reduction activities in pediatric neuroradiology. So let me start here. Here's my disclosure. This is what the patients have when they come and get an X-rays done. In fact, even as of last week, we had a mother sending an email to Dr. Huseman about her concern that her baby had two X-rays, and she read on the internet somewhere that X-rays can cause cancer, and she was so totally horrified, and she was spending the whole weekend really worried about the whole thing. This is the type of you all know patients are coming with these type of concepts in their mind. They are worried about X-rays, and that's where our how we want to communicate and reduce their concern is important. When we talk about radiation safety, I try to group into two categories. One is, what is the radiation safety aspect for patients-wise? The principle of radiation protection or radiation safety for patients' point of view can be justified like the following three. One is justification, second is optimization, and dose limitation. In fact, these are some of the principles of the International Council of Radiation Protection, which discusses in length about this, what needs to be done for patients in terms of principle of radiation protection. For staff, especially for us working around the radiation, the principle of radiation protection can be grouped as time, distance, and shielding. Probably many of you have read this or heard this many number of times. So for patients, the principle is the justification, optimization, and dose limitation, followed by communication. In fact, the communication is increasingly becoming very critical to communicate between the referring physician and the imaging team, which can help to ensure pediatric patients receiving an appropriate exam and optimal radiation dose. As I said, parents comes with concern, and communication became a very critical component in this radiation protection aspect. When you talk about cancer risk or radiation-induced cancer risk, generally, this is the model we generally use it. The average risk for radiation-induced cancer rate in general population is 5% per sievert. Sievert is a very large unit of dose. Typically, we use millisievert dose, as I showed you here. Millisievert dose is 1,000th of the sievert level. As you can see in this graph, generally the 5% per sievert is listed across the board for all the age. In general, it's more, the attributable risk is higher for the pediatric patient compared to the older population. In fact, the children are 2 to 3 times at higher risk than adults, and the typical imaging doses are ranges from anywhere from 0.01 to 30 millisievert at the extreme end. Like some of the PET CTs can deliver up to 20 millisievert, but that's the range of imaging dose we are worried about. But the 5% per sievert is a large quantity of dose. So why children are more vulnerable to radiation than adults? One is the younger bodies are more sensitive to radiation. They have more longer time to develop. And the longer lifetime for radiation effects to impact. That's the stochastic risk takes longer time and the delayed effects. So it's more critical what we do in the pediatric situation. For any given scan techniques, the children absorb more radiation than adults because of the size and everything. So generally, for equal radiation exposure, the child effective dose or the risk is greater compared to the adult effective dose, and that's where the concern comes into what needs to be done to lower or reduce some of the risk. This is just a snapshot. I just found some data. What is the typical imaging volumes in a typical pediatric neuroradiology? Here is just a sample giving a typical imaging study sample. Majority of them are still plain radiographs, followed by ultrasound, followed by fluoroscopy studies, and this particular sample I found had about 3,500 CT scan, not including the CT scan of the head, so that's another additional component. And about 500 of them are body or MRI CT. This is just to give you a snapshot. The majority of the studies done in the pediatric neuroradiology is still plain radiographs, and now it's more and more CTs are also done. What can we do to lower dose? First of all, to minimize risk in pediatric radiology, like we all know that to perform exams only when medical benefit is appropriately high. And how to convey that to a referring physician that it's very much justification is the point, is when the medical benefit is appropriately high, then this particular X-ray imaging procedure is kind of justified. Second important thing is to tailor the exam parameters to the size of the child. In fact, increasingly, hospitals are now pressurized by the Joint Commission, accreditation bodies, and so forth to examine our protocol to see whether the child protocols are child size. And also use under the principle called use minimal possible amount of radiation. We call it as also ALARA principle, as low as reasonably achievable. Third point is image only the indicated area and avoid repeated exam. That's the one area which is difficult to conquer, but it's an area we need to address it to avoid repeated exam. And also to avoid multi-phase scan. Even though most of the radiology department are moving away from multi-phase scan, in a typical radiology department, we see still quite a few number of multi-phase scan is done with and without contrast, or 3-phase study or 4-phase study. That can actually accumulate to the dose given to the patient. And of course, consider alternate modalities such as ultrasound and MRI whenever feasible. These are the different type of radiation dose reduction strategies one can apply. I'm just listed a few of them which are playing a dominant role in the pediatric area. First among the top is the tube current modulation. In fact, this technology has matured quite nicely in the past 5 to 6 years. Now, it is almost unreasonable not to use tube current modulation on pediatric patients. Almost all the scanners in the CT scanners have the capability to modulate the tube current to reduce the radiation dose. Coming down is the lower tube voltage. I'm going to go into discuss in detail into this other things. Iterative reconstruction, minimize scan range. The fourth one is a dose check. This is a new feature which is now slowly coming into all the scanners, which requires the CT users to install in their scanner so that if anyone accidentally changes the technique, that it will alert the technologies that they are doing a high dose procedure or the dose is very high. And in fact, this came as a fallback after the few incidents we had in the West Coast where some patient had a hair loss after undergoing a CT brain perfusion. Education training is a very key thing. And among the pediatric, the Image Gently has played a major role in the past few years, basically through a social media campaign, bringing the awareness about radiation dose reduction importance. So when you talk about tube current, the question comes into picture, how do we tailor the tube current based on the clinical indication? The slide may not be the great one, but I just want to draw your attention here to the mass in the kidney. This mass you can see in all the four slabs. And if we can also want to draw your attention is this was done at 200 MAS, and this was done at 550 MAS. So if the clinical indication is to look only the mass in the kidney, there is no need to acquire the protocol at 200 MAS, which is almost 4 times the dose. On the other end, if you're looking at some low contrast object vessels in the liver, and those vessels will diminish when we reduce the tube MAS very much, because the background noise will diminish the conspicuity of the vessels, and that may not be feasible to acquire at 50 MAS. So there is a need for understanding some of the techniques, how it impacts between the image quality and the radiation dose. So the take-home message is, the decreasing tube current reduces dose linearly, because that's the relationship which has the tube current and the radiation dose are linearly involved. So if you decrease the tube current by 50%, the radiation dose also decreases by 50%. And as shown here, from 200 MA to 50 MA, the radiation dose goes down linearly. With respect to the tube current modulation, as we know, in the earlier we used to have these techniques which the tube current remains same throughout the CT gantry, around the CT gantry. However, there is, as you can see here, the X-ray attenuation is lower in the AP direction and higher in the lateral projection. Therefore, it is possible to lower the tube current when the scanner is acquiring data over the thinner portion of the patient compared to the thick portion of the patient. And that's the principle behind the tube current modulation. Each manufacturer does it slightly variable, but across the board, the physics principle is based on the patient thickness, the tube current is changed. And the tube current as shown here, if it is turned on, the scanner will automatically decide what it faces with respect to the thickness of the patient and ramps up the tube current accordingly so that the image quality is maintained. That's the idea. With this particular technology, with the adoption of this tube current modulation, it has been demonstrated and is very readily seen that the radiation dose to the patient has significantly lowered because of the tube current modulation. Earlier days, it was not so much effective on a pediatric patient, but from the past 5 years, the technology has refined so much. Now, pretty much any manufacturers turning on the tube current modulation does reduces the tube current, the radiation dose to the patient, without jeopardizing the image quality. And there are various brand names from different manufacturers. It's important to understand these manufacturers' variations so that it is correctly applied. The second important parameter in CT is the tube voltage. Tube voltage is an indication of the energy of the X-ray beam coming out of the body, coming out of the X-ray tube, and that impacts the image quality and the radiation dose. In fact, decreasing tube voltage significantly reduces dose, and it's typically to the square of the kV. It's not linear, it's kV square. Therefore, it's not unilaterally decreases, but increases by square. So if you have a CT protocol done at 120 kV, if you simply change it to 100 kV, you have nearly 30% of dose reduction. And if you go down even to lower down to 80 kV, the radiation dose is even higher. And this has been a paradigm shift in the past few years, especially for thin and pediatric patients, because historically most CT protocols are all done at 120 kV, whose energy was sufficient to penetrate the thick portion of the body and also the thin portion of the body. From past few years, most of us are now moving towards lower kV, 100 kV or 80 kV, or even now 70 kV stations, which has shown to reduce the radiation dose significantly in CT. At the same time, increase the image contrast. Another aspect is to limit the sequence or limit the scan. This is one of the studies which Dr. Huseman and we are doing with the neurosurgery residents. The idea here is like in the pediatric, as you all know, a lot of patients come for a repeat scans, especially patients with a hydrocephalus patients, which is shunt placed in the head. They get a number of repeat scans routinely to ensure whether the shunt has moved or located in the same position. So the study to demonstrate, basically showing is here, is two panels. The first study was a retrospective study, basically reconstructing the image on a limited area around the shunt compared to the entire head scan, and thereby studying with radiologists whether there is any loss in the information. And it is shown that there is no loss in the information since you are only looking at the position of the shunt. So, scanning limited to region of interest for evaluating clinical conditions during repeated studies have a significant impact on the patient dose, especially if you are doing a follow-up of the patients very routinely. Iterative reconstruction is a new buzzword in the field of CT. Iterative reconstruction is a technique which applies or allows user to acquire the CT data at a much lower technique, which is basically very noisy image. By doing iterative reconstruction, it can clean up the noise and improve the image quality. So what I meant is like if you're acquiring a CT information at X unit of dose, you can actually acquire a dose at 1/3 the dose, but then go through the iterative reconstruction to improve the image quality. Thereby, the image quality is not jeopardized, but at the same time, you gain the radiation dose reduction. And iterative reconstruction has forcefully entered our field, especially in the past 5 years, and all the manufacturers do provide this information in a slightly variation in the way they do, but in end product has seemed to be quite advantageous to the patient, reducing the radiation dose. Coming down to when you say radiation dose or radiation dose to the patient, we are actually not doing any patient dose measurement. In fact, the CT dose is measured based on the phantoms, and the phantoms are very much standard from the time CT were invented. from 1974 onwards, we are using the same size of phantoms. We call this as the 32 centimeter phantom as the body phantom, a 16 centimeter as a head phantom, and a 10 centimeter diameter as a pediatric head phantom. Physicists use these phantoms to measure the radiation output of the scanner, and we call this a CTDI, computed tomography dose index. It's basically an index number. It's a single slice measurement at the center of the phantom, and we're using this ion chamber, we actually measuring the output of the scanner. From there, we derive what is called as the dose length product, and then arrive at an estimation what is called as the patient dose. So when you say patient dose, we are not actually doing any patient dose measurement. We are based on the phantom measurement. Because of that, there's also a lot of uncertainty in the measurement or the estimation of the risk. The important dose descriptors right now in CT are these two. The computed tomography dose index, also called a CTDI wall, the unit is a milligray, and the dose length product. Dose length products takes into account the entire length of the scan or the scan volume, which is basically a product of the CTDI wall multiplied by the scan length. That's the DLP. For those radiologists practicing in West Coast in California, probably you already know that from this year onwards, we are dictating this information in the patient log. That's actually part of the bill, which now require the radiologist to dictate this information for each patient charts and so forth. Here are some effective dose tables. We're giving a range published in the literature. In fact, this is a little bit outdated information because we are now seeing CT doses at a much lower techniques, at a much lower doses. But these are the ballpark range radiation dose levels seen for a typical adult procedures and also pediatric procedures. And we are now able to do much lower technique than this one. Of course, the various resources available is also enhancing the dose reduction in CT. Among them, the Image Gently has played a very successful in the past few years for bringing awareness about radiation dose to the public and to the radiologist, to the medical physicist and technologist, and providing useful information of how to tailor their techniques, how to tailor their procedures, and so forth. There are other useful resources available. Probably most of you know, and I also highly recommend radiologyinfo.org, which has been one of the forefront website for especially for patients to understand about radiation dose and any of the radiology procedures and so forth. Also, the JACR has a website which is now providing a lot of these CME articles about radiation dose optimization for CT. The latter part of my lecture, I want to talk about update on radiation safety. This confines not just necessarily to CT, but fluoroscopy and everything. The main sources of exposure in any typical X-ray room are these three: primary radiation, scatter radiation, and leakage radiation. When we are working in radiography or CT, we are outside the imaging room. We are in the control console. We are not in the room. The only procedure where we are in the room is in fluoroscopy. And that's where the radiation protection to the staff becomes very critical. So, if you look in any particular X-ray room, the primary radiation is very much confined to the source and the image receptor. So basically the size, the X-ray beam cannot exceed beyond the image receptor. So if you are in the X-ray room, unless you are in the path of the primary radiation, you are not exposed to primary radiation. The things which we are trying to protect is the scatter radiation and the leakage radiation. Even though the X-ray tube is quite shielded, there is some leakage radiation. But when compared to scatter radiation, that is insignificant. So the scatter radiation is the main culprit which we try to protect ourselves inside the X-ray room. And the scatter radiation is influenced by a number of factors such as the field size, the patient thickness, and the type of X-rays we are using. All those things influences the scatter radiation in a room. And that's where the radiation protection for the staff comes into picture, of wearing all the aprons and everything. Here is another example of what the field size, especially in terms of the radiation safety, comes into picture. How does the field size impact not only the radiation dose to the patient, but how the scatter radiation coming out of the patient? 3 panels shown here is the same patient size, image quality is the same, If this particular field size of 30 centimeter by 30 centimeter, almost exposing the whole chest, each black dot is scatter radiation, and each area is half a meter block. So closest to the patient is the largest scatter radiation, and that goes down as you stand away from the patient. It's almost like a butterfly pattern of wings coming out of the patient, the scatter radiation. So if you reduce the field size by 50%, the patient dose decreases by 50%, but the scatter radiation also diminishes significantly. And it further diminishes if the field size is further collimated to the area of interest. And this is particularly important, especially if you're doing a fluoroscopy procedure, where you can collimate to the area of interest. How does scatter radiation is impacted by the patient size? Patient size plays a dominant role. Especially larger the patient, more scatter it produces. Shown in these two panels here is the scatter radiation reaching to the radiologist. For this particular patient, the entrance dose is about 10 milligray per minute. If the patient size increases, in this situation, the patient dose is almost 10 times more dose, 100 milligray per minute. Because of that, the scatter radiation increases from 2 milligray per hour to almost 8 milligray per hour. So the patient dose plays an important role in the scatter radiation coming out of the patient. To capture that, some of the salient features for fluoroscopy dose reduction, which has been that can be implemented in a clinic, is to use the pulse fluoroscopy. Most of all the systems now comes in pulse fluoroscopy to set in a proper way that can reduce the radiation dose to the patient. And there are a lot of filters available which can be used. Then there is to position the patient close to image receptor and away from the X-ray source is very critical. We have seen this case example sometime when this fluoroscopy procedure done outside the radiology. These non-radiologists are doing this, positioning the patient very close to the X-ray tube rather than to the image receptor, which should not be the case. But the bottom line is like the image quality should not be compromised with the goal of reducing the radiation dose. That's the main thing. And also there is, if you're working inside the fluoroscopy room, there are a number of components available in the room and one has to utilize it. Not only wearing the apron, but there is also what is called as the lead skirts, the ceiling mounted shields, which when positioned, which completely blocks any scatter radiation coming to the staff working around the patient. In terms of radiography, the main thing is to use the proper scatter grid and use proper filters to reduce the radiation dose, and also to maximize the source to skin distance. And another important aspect is to verbally communicate, which has become a key to avoid repeat exam, and that's pretty much critical for the technologists when they're positioning the patients and are communicating with them to hold the patient properly and still and so forth. Finally, what I want to discuss also is all this discussion about radiation risk, which we are bombarded with questions. The bottom line there is a lot of uncertainty in the cancer risk estimation. In fact, if somebody asks me what is a patient dose from a particular CT exam, I'm very cautious to say it's an estimated dose is so much, because the number is estimated only, it's not the measured dose. The reason what I want to show this information is like, here is the biological risk from radiation is well established at very high-end radiation dose levels. At the levels of like 400, 500 millisievert or half a sievert doses. But at the radiation dose level which we see in imaging, which is typically less than 0.01 to 30 millisievert, we fall in this range, which is basically a very uncertain area where we don't have substantial human data to support one side or the other. Because of that, various model has been proposed, and for radiation protection per principle only, we use a linear model, which is basically no matter how small, there is some risk. And that, in fact, has brought a lot of confusion to the whole thing. So in general, there is no strong evidence for long-term cancer risk for the imaging doses. However, this uncertainty has muddled discussion on radiation risk. So in this situation where we have this uncertainty, it falls upon us to take all necessary steps to minimize any associated risk, and that's the one which we have discussed. So what's in the future? In fact, for radiology, the way the discussion about radiation dose reduction in the past 5 years has really impacted significantly of reducing the radiation dose. Here is, for example, here's one from my colleague, a chest CT on a 3-month-old. done for a complication of the surgery. These numbers, which was not unheard of, is now possible in CT. A very low technique, almost 34 at 1 milligray or 20 milligray centimeter. It's almost come to the point of the measurement error because the radiation dose has gone down significantly. With the implication, with the application of the iterative reconstruction and the type of reconstruction, the radiologists are comfortable of reading this exam acquired at such a low technique. Here is an example, low dose CTs which are now coming to the clinic close by. Here is an example shown. The effective dose values from CT exams are coming to a closer and closer to a radiographic exam with a greater information available with the CT. Shown here is a chest CT and abdominal CT. Especially for a pediatric, as you all know, a CT takes a fraction of the second, has its inherent advantage of scanning the patient and so forth. Now, along with it, we are able to reduce the dose in the CT. Therefore, you can comfortable about the radiation dose from the CT. Here's an example which was shown recently, an image of an MR versus a CT. The CT is now able to demonstrate the low contrast resolution almost equivalent to that of MR images, which is giving a major boost for the CT image. Finally, I like showing this image because the chest CT dose is almost becoming closer to a chest X-ray dose. And here is an example. These are two images. First one is from a chest X-ray. The effective dose is about 0.06 millisievert. And here is a multi-detector CT with the iterative reconstruction special technique, and the effective dose is about 0.5 millisievert. So that's the direction which we are moving and we are able to acquire now. Finally, the benefits of the CT studies have shown far outweighs the radiation risk as long as appropriateness is justified. The CT technology has evolved over the past 4 decades, especially in the last 8 years. It has really heavily evolved towards dose reduction. And these technological advances and the optimization are enabling significant dose reduction. So basically, it's up to us to understand this and start implementing in our clinic to provide the CT exams at a much